Good morning. My name is Shri Zahir, and I'm the Dean of the Carlson School of Management. Thank you all for joining us for the 4th annual Convene conference. However, this is the first Convene conference hosted by our brand new Business Advancement Center for Health, or BACH, at the Carlson School. Launched in January of this year, the center's vision is to create a healthcare system that delivers equitable care to all. BACH works towards this vision by designing business-driven innovations that address gaps in health equity and by creating conversations to improve value in healthcare through convening academia, industry, and community stakeholders. The center is a hub where faculty, students, industry leaders, and community stakeholders from all disciplines can collaborate to tackle these pressing issues that we face in health. BACH evolved out of Carlson School's research and outreach efforts in the health sector, including the award-winning COVID-19 hospitalization tracking project led by Professors Pinar Karacha-Mandik and Soumya Sen. We are excited about the potential for BACH to use business as a force for good to make healthcare equitable and accessible for all, especially as we come out of this pandemic. You will hear from an excellent lineup of speakers throughout today's program at the intersection of healthcare and data science. A big thank you to our speakers, moderators, our conference sponsors, and the entire BACH team for making this year's conference possible and for the contributions all of you make to improve access and affordability and equity in the healthcare system. Now, it's my pleasure to welcome Professor of Finance, Pinar Karacha-Mandik, the founding director of BACH.
Thank you so much, Shri, for that introduction, for those opening remarks. For the past 10 years, Dean Zahir has been a valuable resource and champion for the Carlson School of Management and its various programs. And as Dean Zahir mentioned, the Business Advancement Center for Health, BACH, was launched this past January. And as the founding director of BACH, I'm extremely excited to spearhead this new research center through reimagining health and healthcare. Through designing and evaluating next-generation business models, BACH innovates evidence-based and data-driven sustainable solutions that will effectively address critical gaps in healthcare cost, access, safety, and equity. We have constructed BACH's framework on the principles of 4 C's. The first C, convene, as we are today, joining the stakeholders in the community, academia, and industry to share insights. The second C, conduct, collaborative research by cross-functional collaboration efforts. The third C, co-create, innovative business models by the findings of our research. And the fourth C, communicate our findings to the healthcare community. BACH will continue to grow Carlson School's expertise, focus on partnerships with the healthcare community as a thought leader and as a convener to tackle these critical issues in healthcare. And as Dean Zahir mentioned, we're extremely proud of our COVID-19 hospitalization tracking project. This project received global and national attention from major news outlets, various business awards, and being named a finalist of the NIHCM Digital Media Award. One of our prominent annual events of BACH include our recent University of Minnesota Interdisciplinary Health Data Competition. This event promotes collaborative and collaboration with interdisciplinary teams using data to address current healthcare challenges. And furthermore, we are here today at the 4th annual Convene conference. I'm excited for our event today, focusing on the consumerization of healthcare and digital health. As a background, Convene started in 2018 with a focus to bring together academic researchers and medical industry executives to share their unique perspectives on trends, opportunities, and challenges in healthcare. And as you know, our Twin Cities has a thriving medical ecosystem where the conference promotes cross-disciplinary learning of various leaders in our community. In the healthcare space, this is one of the most valuable areas where we can be coming together to share insights, data, and hear what's going on in the broader community. In order to be innovative, it takes us coming together, providers, advocates to support new ideas, new technologies, and deployment of these into our healthcare system. Thank you to each and every one of you today, our audience members, for joining us virtually. Our event has traditionally been in person. However, we have pivoted to a virtual format to accommodate our speakers and to provide the opportunity to capture a national audience. Today, we have a group of engaging leaders from our healthcare community that our audience will truly appreciate hearing from. We appreciate the time you've set aside today to share your valuable insights and perspectives. I would also like to take a moment to recognize our sponsors. This event would not have been possible without your support. Our presenting sponsor is United Health Foundation. Our gold sponsors are Medtronic, Optum, and University of Minnesota Office of Academic Clinical Affairs. Our maroon sponsors are Blue Cross Blue Shield of Minnesota, Frederickson Byron, and Mayo Clinic. And I would like to also thank our conference steering committee, our Carlson executives and residents, Dr. Arkel Giorgio and Gopal Khanna, Box program manager Kim Choi, and MBA student committee members Nathan Jones, Ikram Khan, and Daniel Magee. And now it's my pleasure to introduce Gopal Khanna, who will introduce our keynote. Gopal Khanna is the former director of the Agency for Healthcare Research and Quality, where he served from May 2017 through January 2021, leading the agency's mission of producing evidence to make delivery of healthcare safer, higher quality, more accessible, equitable, and affordable. Prior to his role with AHRQ, he was the director of Illinois' Healthcare and Human Services Innovation Incubator, and he served as Minnesota Governor Tim Pawlenty's as a cabinet member, commissioner, and the state's first chief information officer. Gopal has held various senior executive positions in the administration of President George Bush, including CFO and CIO of the United States Peace Corps and CFO of the Executive of the President. In 2020, we were honored to have Gopal join the Carlson School as an executive in residence for the Medical Industry Leadership Institute. Thank you and welcome, Gopal.
Thank you. Thank you so much, Pinar. I appreciate this. And good morning to everyone. It's indeed a great honor and privilege for me to introduce our keynote speaker this morning, Mr. Aneesh Chopra. He has an extensive background, but let me give you some highlights. Aneesh Chopra is the president of Care Journey, an open data membership service building a trusted, transparent rating system for physicians, networks, facilities, and markets on the move to value. He served as the first United States Chief Technology Officer under President Obama from 2009 to 2012. In 2014, Aneesh authored Innovative State, How New Technologies Can Transform Government. Aneesh serves on the boards of the Healthcare Cost Institute, International Digital Accountability Council, and chairs the George Mason Innovation Advisory Council. Aneesh earned his MPP from Harvard Kennedy School of Government and BA from the Johns Hopkins University. Ladies and gentlemen, I have known and worked with Aneesh for almost 20 years. He's a visionary leader, always bringing to the table unique, disruptive, and creative solutions to complex issues. Aneesh understands the healthcare space better than anyone I have met. Ladies and gentlemen, I'm proud to present to you an accomplished executive, successful entrepreneur, and a distinguished public servant, my friend Aneesh Chopra. Aneesh, please take it.
Hey, Gopal, thank you for that very, very kind introduction. I feel like dancing, running down the hall, high-fiving. Wish we could all be in person, but I think we'll make the best of the environment we're in. With your indulgence, I look forward to sharing maybe an initial set of remarks, and then you and I will have a little bit of a dialogue and any we can pull in from the audience. The topic I wanted to highlight today was this notion of consumers at the center. While the topic of consumerism has had much debate, this is an opportunity, I believe, to put a little bit more texture on the nature of that debate by focusing on where open data and APIs combined with the changes in how our healthcare system is paid for will, I hope, result in a marketplace of what I'm referring to as health information fiduciaries. So my goal is to maybe sort of be a little bit more provocative about the vision, but also a little bit more descriptive about the enabling ingredients that have been made available through regulation or industry acceptance over the last several years. So let's spend a few minutes just framing the discussion and maybe using it as fuel for our debate. First and foremost, and I think I'll start with some sobering statistics, the role I held in the Obama administration as Chief Technology Officer included a very specific focus on American competitiveness. No matter how you slice and dice it, we're less than 5% of the world's population. We're approaching whatever 25+% of the global kind of economic output. We punch above our weight in the United States. And one of the vexing questions for policymakers is that, will that be a sustainable leadership role? If we looked forward a decade, 2 or 3, will we see that same outsized economic performance for the population we represent, or will that shrink as countries like China and India emerge? One of the assumptions going into that debate is that if we rein in excess health inflation, that is health inflation that exceeds overall economic growth, that in a sense, it operates akin to a tax on the innovative capacity of the country. So linking the idea of health inflation constraint and American competitiveness, it does remind us that we haven't yet cracked this code. We have just revised from the actuaries at CMS a kind of a sobering look over the next decade about where healthcare spend will be relative to GDP. That number is not going down, it's going up. We have also had a bit of a policy debate erupt over the last 3 months that asks the question whether we should be relying on public-private market solutions to address this issue, or whether we sort of raise our hands and say it's time for a Medicare for all, where we have a single payer system and maybe look more like the rest of the industrialized world. You saw this very specifically in the Congressional Progressive Caucus when Congresswoman Jayapal led a coalition of more than 50 of her peers to call for the end of what had historically been a massively bipartisan bet that if we changed the way we pay for care, we rewarded better outcomes, we would achieve that triple aim of healthcare costs, quality, and customer satisfaction. Well, that was the first shot across the bow. Policymakers like my good friend Michael Chernew have responded with a proactive case, bullish on the role of accountable care. But we're going to face this debate vigorously over the next decade as we try to grapple with the theory of change with the reality. And you'll get to the punchline. I'm hopeful that this new empowered consumer in this health information fiduciary model may give us a path forward that will deliver better results than we've seen in the most recent decade. So what has the most recent decade looked like? There are a few wins that we can point to that move the ball down the field. First, on the open data front, this was my assignment from President Obama on day one, to make the government itself more transparent, more collaborative, more participatory. And nothing was more relevant to that agenda than finding a way to release the Medicare data to inform the American people about what is or is not working about our healthcare system. Prior to the Obama administration, it was illegal by court decree for CMS to publish any information about how much money it would spend on an individual doctor. It was a perception of a privacy violation to know how much money doctors have earned from the Medicare program. We flipped the narrative, and by 2013 or so, public use files began to emerge. You saw that Wall Street Journal, which is the screenshot you see in front of you, but New York Times and other media properties began mining that data. And one of the first aha moments was, who was the highest paid doctor in America in 2015 from the Medicare program? And it turned out to be a doctor in Arizona who's an ophthalmologist. And you might say, my goodness, at $100 an office visit, that seems like a heck of a lot of office visits to get to 11 million. Well, you're right. It wasn't the office visits or procedures. In fact, it was the injectable drugs. the retinal specialists inject very groundbreaking kind of innovation. You can stall the progression of blindness in a population. And so, miracle. Doctors can bring you into their clinic. You don't have to go to the hospital. They can inject your eye once every 6-8 weeks, and you actually can keep protecting your eyesight. Now, what's uncomfortable about this is that there are actually half a dozen, maybe 4 ways you can inject this drug, or options on what drugs to inject. The majority of these drugs are branded, and they charge anywhere from $2,500 an injection to $3,500 an injection. However, there's a $50 version of the compounded, a compounded version of the drug Avastin that could retail for something like $50 as it relates to consumer price. So imagine this beautiful story, researchers digging in, and NIH published not 1 but 2 studies suggesting that there are clinical equivalents. You have a $50 injection that can stall blindness, $2,500 injection, $3,500 injection. Guess what the American people get in the current economics? Yes, overwhelmingly, they get the more expensive option when the $50 version was clinically equivalent. And this particular doctor is paid $11 million, in part because it's almost like 100% of the patients he treats are in that category. Now, I will say that there's plenty of room for clinical judgment here. But as we understand the role of an empowered consumer, maybe 10% of the Medicare population has to pay a 20% copay out of pocket for that drug. So a doctor tells a patient, you're going blind, and I can save or stall that blindness. You have to allow me to inject this drug, and here's the cost. What conversation is had about the fact that there's a $50 alternative versus a $2,500? Every 6 weeks, 8 weeks, you got to inject that drug. Makes no sense to me. Yet that's the system in which we operate. So that's open data. We've now released more information. We'll talk more about that momentarily. The second topic is that we began releasing individual information to apps of their choice. As many of you know, one of the bedrock principles of our investment program in modernizing electronic health records going back to 2009 had been that the consumer should be given machine-readable access to their data. Not because individuals are going to read it and understand all the minutia and the jargon, but that there would be a growing marketplace of applications that consumers trust that could help them interpret it. And by providing machine readable, as opposed to just human readable copies of their medical records, we could accelerate this industry of navigators, assistants, advisors. So where did we see this functionality come into play? Well, in the pandemic, one of the first things that we had to do was to basically demonstrate that we've been vaccinated to get access to sporting events or restaurants. And a group of stakeholders in the FHIR community, FHIR is the open API standard that's now regulated in healthcare, decided to come together to build on the progress over the last decade to make it so that this simple piece of information, verification that you've gotten the vaccination, could be shared from the EHR systems or the pharmacy systems where you had the shot administered, frankly, even the state immunization systems where that stuff is captured, and can store it on your own mobile device. Both Apple and Android now have full capability to store this completely free of charge for individuals to use. So it's been a decade of progress on opening up data and opening up clinical information to trusted consumer designated apps. What I'd like to suggest to you is that I'm bullish on the next decade for consumerism, not because I think that the consumer experience is going to mimic what we do when we shop at a retailer like a Best Buy, and we'll talk Best Buy's be with us shortly, or an Amazon.com, but that rather we will start to see these enabling ingredients I'll describe fueling applications we trust. Let me just quickly summarize the 5. I'll spend a minute on each, and then Gopal, you and I will have a bit of a dialogue about it. First, and obviously most important, I need to know which doctors I can go see in my network. And so making sure that we hold payers accountable for maintaining accurate physician directories so that when I buy insurance, it's clear to me what I'm allowed to access in the healthcare system. This is what led to the surprise billing fiasco and all the other challenges. We've got to do better. Congress has taken action. You'll see a lot more regulation in that space. Number two, that very same data that allowed us to see how much money Medicare spent on a given doctor, now there's actually an opportunity to go deeper, all the way down to the underlying claim line level detail. Congress asked for the American people to benefit from this release of information for the purposes of understanding provider performance measurement. So can we move beyond just the online Yelp reviews and a neighbor's trusted voice about which doctor is the right one for me, and move towards one that feels a little bit more about the, that fits a bit more my clinical need? I have a right as a consumer to request real-time pricing before I go in to get that procedure done, that medication that we just talked about for the injectable eye. I could ask for a good faith estimate. Congress enshrined that in the No Surprises Act, which the administration is now putting the rules in place so we can ubiquitously offer a good faith estimate. If it's good enough for my Jiffy Lube when I get my car fixed, I deserve a good faith estimate when I'm going in for a complex medical procedure. We talked a bit about that consumer access to their own clinical information that continues to scale. And last but certainly not least, I can not only choose my doctor, but increasingly there are competing health networks that will work with me to reach not just the doctor I need, but to wrap around the support services so I can get the best possible care. One important caveat as we get into this conversation, Gopal, I'm not sure that consumers are going to trust big tech. A survey from Rock Health suggests that big tech ranked dead last on organizations they would trust for data sharing. Look at the very top of that survey. It's apps recommended by my doctor and maybe my insurance company or pharmacy that are much more trusted. This era of health information fiduciaries may simply be an extension of the existing trust that we have within the healthcare delivery system. So let's go into each of these in order, and then we'll lift up and get ready for a bit of a dialogue. First and foremost, I asked the question earlier on provider directories, but my God, it's so maddening. 60, 70% error rates in these provider directories. No one's held accountable. I look up the phone number, I call, and it's the billing office, or it's an it's a decommissioned phone number. The address in the book tells me to go somewhere, but that's the billing office. It's not the doctor's location. The doctor's location is not convenient for me. So how do we strengthen this? The good news is that regulators have now put more pressure on all plans, employer-sponsored plans, government-sponsored plans, to release that provider directory and to maintain its accuracy in a much more timely manner with accountability provisions for a quote unquote lying to your customers if you've misled me on what my directory looks like. The good news is we've got a top-down and a bottom-up approach. Not only do we have government regulators kind of pushing it from the top down, you've got search engines like Google and Bing from the bottom up, scaling up tools to make it easier for doctors to have their relevant insurance information and other content, including appointments, for example, available right in our search experience. So that's new and that's exciting. You can see, I don't know who Dr. Greg Saunders is, but I had fun just sort of playing around with the internet. You could see that, we've got a long ways to go. Dr. Saunders has accurate information on his website, obviously, where he practices, what he does. But when you go to some of the payer sites, and in this case, I didn't choose to pick on a private plan, I picked on Medicare. The Medicare database hasn't been updated since 2007. And so the information is not accurate. The good news here is that we're making great progress, and keep your eye out on the regulations to ensure that the information will find its way to you and to apps you trust. I want to go into that price estimate next, which is what exactly is a good faith estimate? CMS and the Congress, actually, through CMS, is finalizing regulations to define a good faith estimate. And the principle behind the good faith estimate is that it should not only cover items that are like the doctor's fee, but quote unquote, items or services beyond the period of care for the scheduled or requested primary item or service. In other words, a bit of an episode bundle. You can see a sample of what a good faith estimate might look like for colon cancer. Yes, there may be a colonoscopy. There may be some pre-surgical physician visits or labs that are drawn. You might actually have the procedure that involve the pathologist, the anesthesiologist, a hospitalist, and other consultations. You might need treatments in radiation to go to a clinic in the community. And then you might want to continue monitoring that condition to ensure that we've removed the cancer and that we're keeping individuals where they need to be. That bundle of care is today not easily constructed. So much of the healthcare fragmentation of data has resulted in proprietary models to organize that data. It's maddening how many different hands we have in the vendor cookie jar just to answer a simple question: what is the good faith estimate for treating my colon cancer? Well, CMS back in 2011 and 12, through the Affordable Care Act, did fund a completely free and open source grouper called the Episode Grouper for Medicare. Brandeis University was awarded that contract, and they've created now a nonprofit center called PACES to establish a bit of a coalition of the willing who can work on open definitions to democratize access not only to the underlying data, but to the logic bundles that puts them together to make them meaningful for people. I also wanted to highlight that it's the consumer that has the right to initiate the good faith estimate request. CMS has put this handy dandy little sample form on the web to educate consumers that if they make this request, the burden is on the providers to assemble that estimate, working with the health plan to give it not only to you in your in kind of the cash price world, but to go through your insurance system in advance, what's called an advanced electronic explanation of benefits, so that you could actually know what the actual experience will look like before you incur any fees. It's sort of the pre-surprise billing phenomenon. On the issue of who the best physicians are for me, Gopal kindly reminded us that in disclosure, this is what I do for a living at Care Journey. I'm very excited about this part of the Affordable Care Act because it says, as you can see, Section 10332, this is the provision that called for the release of Medicare data for provider performance. Now, in Care Journey's mindset, historically, we've seen health plans build proprietary scores on who's a high-value doctor or not, run on proprietary data sets. Not a lot of trust when you can't really see the black box or reproduce the results. We believe it's high time to leverage all of that openly available data. Now that Medicare, Medicaid, Medicare Advantage are all publicly accessible in a linked longitudinal database that actually is managed by the University of Minnesota at ResDac, that is accessible for the American people to reproduce analytics. So Care Journey takes openly available algorithms, run on openly available public data, so we can create more trust in building a more data-driven system. You can just see a snapshot of what we do, for example, within orthopedic surgery. And I just highlighted three simple examples. One, while orthopedic surgery is a generic category, we believe it's important to sub-segment the population into the procedures they actually treat and the patients they treat or the conditions and services they render. So step one is to kind of clean up the search terms. So I'm not just looking for orthopedics, I could be looking for an adult reconstructive surgeon, and you can help me compare across that subgroup. Second, we want to make sure that it's relevant for patients like me. Using that open source episode grouper, patients that have osteoarthritis, that's been a clinically defined group. So you get a sense for what the cost structure looks like when treating someone who's got osteoarthritis. And you can figure out my third point, given what we know about the nature of the services rendered, how much variation is there by doctor in my neighborhood in terms of how they treat patients with osteoarthritis, risk and mix adjusted. And so might there be a way to understand what a benchmark looks like and what a performance change might be relative to that benchmark. on cost and then claims derivable quality. So to me, this is the third question. The fourth one is, can I actually share my health data, i.e. get rid of the forms? And what I'm excited about, and I've highlighted Apple Health and Common Health because these are the free open source, let's call them the public option of consumer designated apps. We know Apple's done a great job attracting a sizable market share in the United States. Android has picked up quite a bit. And regardless of what phone we use, we can now store our medical records out of a doctor's EHR system and into the hands of our mobile apps. A few things I'll point out, great deal of transparency here. Apple has been publishing every single one of the 10,000 plus locations that have freely connected their EHR systems to Apple Health. This is exciting because it actually means that that location has gone through a strict data validation step so that the content flowing from the EHR into the mobile app meets all the technical standards. And so Apple is rejecting physicians whose EHR systems don't pass the test. So that's great news. Apple's kind of playing the role of real-world regulator to make sure that the data flows. Similarly, Common Health has not only followed the Apple Health connections, because the marginal cost of adding an Android to an Apple connected system is basically zero on the EHR side. Common Health has actually gone beyond it, working with Cigna to load for the first time health plan data in addition to EHR data, so that you can start to collect both sources for free on your phone. Finally, Apple is pushing the envelope in terms of sharing that information back with my doctor. So there's now a mobile app that, I should say a feature in the mobile app that would allow me to push my records to my physician. And you can see Cerner is one of the first EHR systems that loads the Apple Health free mobile app natively inside the Cerner EHR environment. So a physician simply has to connect the Apple Health app tab, and the information in it that the patient has shared presents itself. It's not that a stretch of the imagination to see a world where instead of asking me to fill out the clipboard, all you'd be asking me to do is connect to my mobile app to source all that relevant information to pre-populate that form. That day is coming, I promise. Last but certainly not least, can I select my own network? Now, this is a little bit more complicated as it relates to payment reform, but part of what's happening in the world of accountable care is that the doctors we see in the community, and for those of you in Minnesota, my good friends at Fairview are the first to take on this model. CMS launched an experiment. If I could build a capitated premium for traditional Medicare patients who have the freedom to go anywhere to see any doctor they want, I can work with your primary care doctor at Fairview, and they could manage my entire budget. Maybe it's $10,000 to $12,000. Put more resources into outreach and preventive services, maybe screening for my social needs, figuring out whether there are things we can do to slow down disease progression rather than wait for me to end up in the ER and care for me on the other side. That program has a very powerful feature. Not only are the doctors at Fairview enrolled in this program, but I, as a consumer, can choose, not just I want to pick my doctor, but I can actually pick my doctor in the context of this network where I may get the benefits of more coordinated care, discounts when I see high value providers in the network, and also beneficiary incentives to organize my preventive services schedule. Eat healthier, stay in consultative mood with my dietitian to eat better, and so forth. So Gopal, these are enabling ingredients for a world where consumers will have more say, more engagement with the delivery system to benefit from all that the American healthcare innovation economy has produced. But I believe transformation here will run at the pace of trust. We remember the articles when Google announced the partnership with Ascension that didn't break any laws, but certainly the quote from the Atlantic Monthly came across as totally creepy, right? Where Google was theoretically accessing all your medical records, indexing them, and making it easier for doctors to search for relevant information inside their EHR. I've been calling for a digital Hippocratic oath in the 21st century, working with a nonprofit interoperability framework called Graphite, where I'm an advisor, that is helping to bring Kaiser Permanente, Intermountain Healthcare, Presbyterian New Mexico, SSM Healthcare, and many more that will sign to agree upon rules of the road for data sharing. I also co-chair the Karen Alliance, Gopal. We've gone beyond HIPAA. So those third-party apps that are competing for my trust to store my medical records, we are asking that they sign onto a code of conduct that agrees to disclose not just what they're going to do with my named data, but even what they intend to do with my de-identified data, which today in the HIPAA environment is, once you've de-identified it, organizations are selling that data on the market left, right, and center without any real feedback to us because it's not protected under HIPAA. I will say that that marketplace of trust, Medicare has begun launching its own apps marketplace. Something like 80 applications are live. I understand that Best Buy is on the following panel. Their Lively program is one of the 80 approved CMS Blue Button apps. So it's an amazing example of where I believe we'll start to see competition, not only to access and use your data for good, but with greater privacy protection so that you have confidence on the services that will now compete for your time and attention. And with that, Gopal, I'll pause and I'll turn to you for a bit of a dialogue.
Thank you, Aneesh. That was an excellent presentation and you've given us much to think about and talk about. I would like to thank you once again for your willingness to stay on for a bit, to take a few questions from the audience. And for the attendees, I would urge you to use Zoom Q&A function to submit your questions. I've already seen a bunch of them already come in, and my colleague, Professor Pinar Karaka-Mendik, will collect them and help me moderate this Q&A session. Given the fact that there's limited time and there are already a lot of questions, Aneesh, I'm going to start with a couple of them myself here first, because I do have a long list of questions. But to get you started, talk a little bit more about, since the theme of this conference is consumerism of healthcare and digital health, I would like to come back and get some more clarity on consumerism in healthcare. The reason why I say that is because when you do Google search and say, what does consumerism mean? What it really means is government putting in a lot of investment into the marketplace so that the consumers buy more and the suppliers of services and products ramp up their production capabilities, and therefore the economy grows. Now, with that kind of a baggage in terms of consumerism as a way to describe the activity as it pertains to healthcare, seems like there's some kind of a disconnect, because in healthcare we are looking to bend the cost curve and improve the quality and delivery of services. So just talk a little bit more about consumerism, how you see it.
Yeah, markets are remarkably efficient. You get what you pay for. And in today's fee-for-service system, what is rewarded is more visits and more services. So it's not irrational to expect that in today's fee-for-service system, consumerism is about scheduling features, billing features, documentation capture features, which are all part and parcel of a fee-for-service economy. But what I'm hoping for, Gopal, is consumerism in the move to value-based care will result in new products that will compete for my time and attention. Specifically, advanced primary care models that take on that total cost of care risk. I believe a new chapter of consumerism in value-based care will be about picking those networks. It's that last slide I highlighted that maybe I should have put a bit more emphasis on, where the products that are coming to market are, yes, maybe I'll come to my primary care doctor and they may earn more resources in kind of managing my kind of preventing myself from having suffered more disease progression. But that today is not marketed in the same way your traditional new appointment scheduling Google search kind of ads look like. So we need product change with value-based care, and then to empower consumers to engage. And then for those models to be successful, that primary care doctor may not have access to your medical records because you're seeing specialists in the community and you're going in and out of the network. So being able to work with consumers to ensure that that primary care physician has the information they need, that's where we start to see all these features and enablement functions come together.
Thank you, Aneesh. Pinar, would you be so kind to chime in and talk about some of the questions we have received from the audience?
Yeah, absolutely. Lots of questions came in with the limited time. What I will do, Aneesh, is I've kind of grouped the questions into two buckets, and I'll put it all out there and you kind of respond as you wanted to respond. So one of them is about sort of this transparency, interoperability, and the response. So specifically, one speaker is asking about the responsiveness of the payers. For example, when you think about the directories, the doctor directories and cost agreements, right? The other audience member is asking about the provider's response. How do you feel providers and healthcare institutions have been responsive to this transparency? And then the third audience member is asking about the EHRs. How have EHRs responded to these requests? So the one bucket of questions is maybe you can comment on the relative responsiveness of these different stakeholders. The second question I would group under sort of whose responsibility is it? And so it kind of builds on, right? So why should the patients know there are less expensive drugs available? Isn't it the provider's role to provide that information? And then another audience member saying, well, why is it up to the providers? You know, they don't have enough time, right? And then the third audience member is saying, well, you know, let's look at some of the public health efforts, and why should the consumers have to make sure the providers have access to their records and the history and information? Is it maybe we should think about the national medical record system, and that's where the responsibility belongs. So I'll leave it out there as I try to group maybe 7-8 questions in this.
Pinar, these questions, I love seeing them because you understand the tensions we face in shifting an 18% of the GDP economy when we've got massive fragmentation and built-in incentives. So the short answer is it's a tale of two cities. The regulations and transparency have been mostly about compliance to force the data out begrudgingly. So most of the effort, if you go to any of the stakeholders who are participating in today's session, what does this transparency mean for you? What that really means is we have to hire an IT program to take information, put it on the web. Nobody's using it. What a waste of time. This is a government mandate, blah, blah, blah. So 80% of industry response is begrudging compliance. However, the tale of two cities is that there are increasingly stakeholders who see an opportunity to interpret this information to help people make better decisions because they're going to be rewarded for it. That group I described for you as that network of doctors taking financial risk, it is in their best interest to make sure I'm up to date with my preventive services. I don't avoid or skip that medication refill. And being able to stay more on top of these issues is in their interest. The incentives are aligned, but they're a small portion of the healthcare delivery system, but you can sort of see when you squint your eyes a bit of the window into the future because they are demanding the use of this information to help them manage those populations. Now, because we're predominantly fee-for-service today, that begrudging compliance is the narrative, which is why you have very little interest on the sources of data actually studying whether or not anybody is benefiting from this on the other end. And Pinar, let me ask a simple question. We learned in the Medicare Innovation Center through a project we helped fund before I left the administration in 2012, that if you're pre-diabetic, we put you on all kinds of meds, and then of course you risk getting diabetes, and then you have all this downstream infection, and it's a really difficult condition to manage. But if you're pre-diabetic and we can get you a $600 voucher to the local YMCA, your A1C levels will fall. And the percentage of people that are pre-diabetic that graduate into full-blown diabetes falls. The CMS actuary famously wrote a 4-to-1 return on taxpayer investment. For that $600 voucher, we get $2,400 in savings. People are healthier, they've been coached to eat better, they live longer, and what a win. On the evidence generated by the actuary's signature, every single doctor in America, Pinar, can prescribe the YMCA voucher to a pre-diabetic. How many people last year, 2020, when I last looked at it, across the entire country, hundreds of thousands, if not millions of pre-diabetics in the Medicare population, how many received the voucher to go to the YMCA class?
Very low.
Less than 1,000.
Wow.
You want to talk about consumerism? How do we think of a little digital guardian angel that sits on our shoulders, as MIT, a research team at MIT famously coined in a proposal to DARPA? Imagine if for my own loved ones, I could identify that they're eligible for this service. Wouldn't consumerism mean, let me get the voucher, let me call the local Y, let me make sure they can make this class available, let me schedule the appointment for my mom? Like, that's how the system should work. Yet instead, we sort of have this paternalistic, oh, shouldn't it be the doctor's job? Should it be Medicare's job? Whose job? It's all one of these things. So in my opinion, we need alignment of interests through payment models that reward doctors to actually study these things. We need tools to help them, make it easier for them to figure out that, oh, I'm eligible, even though I haven't had an appointment in a few months. They might want to proactively remind me. And then we need to have a system that makes it as least friction filled as possible to do the right things and get the benefits. So long-winded answer by saying, you see the pieces.
Yes.
We need someone to put the pieces together and scale. And I hope with these 5 enablement tools, we're going to get there.
And then I would add one thing you said, the transformation at the pace of trust.
Yes.
That also builds up. Gopal, would you like to conclude? Thank you so much, Aneesh.
Aneesh, I wish we had more time. We are respectful of your availability this morning. So I'll have to say thank you so much once again for taking the time to be with us. My hope is that we'll have you come here in person and meet the Minnesota community and other leaders all across in the healthcare sector. But thank you once again. Ladies and gentlemen, please join me in giving Aneesh a round of big applause virtually. Thank you.
Thank you so much. Now we will go on a break until 10 o'clock, where we will welcome our first panel. Please stay with us and we'll see you in 10 minutes.